you kindly invited us over to meet with you, and after we had that meeting, I think we were really psyched to come up and visit with you and think about collaboration. And I tell you, we're very interested in doing collaboration. I think the kind of work you're doing really fits into the sort of issues that we're facing day to day in clinical research. So I'll have to continue that discussion, and I appreciate the opportunity. We were just talking a few weeks ago about how it would be nice to come up here and do contact tools. Thank you for that.
Great. Excited to be liberated on that. So I have a couple of goals today for the talk. Some I've been asked to do. I mean, for example, I want to tell a little bit about the trajectory of my own career, and I'll pitch that kind of through the process of presenting some of the research I've worked on. I think a lot of the projects I have conducted really mirror what's been going on in the field, so I want to sort of present it to you that way. Also, hopefully educate you a little bit about what's going on in HIV right now. And I think one of the themes I have, which really comes up in the title, is the issue of collaboration in research, cross-disciplinary collaboration. I think that's probably never been needed more than now. So I want to address that in the context. And also, I'm going to try to fold in a little bit about career opportunities for students and sort of career paths. And I've highlighted some of the students I've mentored over the years as well. So that's my general goal for the meeting. Let me just start by saying, you know, the global HIV epidemic, it's been around a long time now. It started back in about, I guess, the 1980s. Treatment came along around 1990, almost a decade into the epidemic. And as time has passed, we've been hoping that this would abate. But I have to tell you, in some parts of the world, it's just striking how this epidemic persists, even given all the knowledge we have about prevention, the technologies that are in place, the treatment advances. The challenges are really enormous. And I think that there really have been sort of eras of what's going on in the field. I also want to just say that I think there's a bit of a problem that's been out there from the beginning, which is this magic bullet thinking. This idea that we're going to find the magic bullet, find the thing that's universally and rapidly effective, that's easy and inexpensive, has no side effects, and will be permanent. And that's really, I think I've come to the conclusion that we're probably not going to find the magic bullet for HIV. You know, I was thinking about, on the way over here, you told me of a student that went through to Tanzania and had an oral infection and took an antibiotic, and how dramatic it was that the swelling went down and they were better within a day. You know, that's the sort of magic bullet technology we've had in many of the sort of serious health issues we've had. And I think that magic bullet thinking has actually hurt us a lot over time with HIV. It's led to a lot of competition. It's led to sort of people in prevention versus the biomedical side, the treatment side versus prevention, competing with one another. I think the more and more I've worked in the field, the more I've started to see that, you know, those are really detrimental, that we really need to work together and collaborate. So I want to just pick up on that theme as I discussed today. I do think there have been some errors in the HIV field, sort of in the early days when this was first out. You know, the major theme in the public's mind and in the scientific mind is really fear. It was a really scary situation. We weren't sure how it was transmitted. We weren't sure who was vulnerable. We didn't have any technologies to actually diagnose people with HIV in the beginning. We didn't understand the pathology of HIV. So most of the early studies really were epidemiological, just trying to figure out those processes. And then I think also a lot of social and behavioral work was going on at the time, because there was enormous stigma towards people with HIV, which continues to be a big barrier. And as well, there just weren't any biologic or biomedical technologies in place to really address the epidemic. So it was enormous growth in social and behavioral science around HIV, and a lot of the lessons learned in that have actually been translated into other areas of health prevention and promotion. Around the middle part of the 90s, and I was at this meeting in Vancouver in 1996, when the first scientific reports were released about the effectiveness of ART, of antiretroviral therapy. It was an incredible moment actually to be there when these results came out over a decade and a half into the epidemic, when suddenly we had technologies, we had drugs that could keep people alive. And it was really dramatic to see the rapid death of people, the horrible death that was happening. It was affecting massive numbers of people in developing countries. I think perhaps it was an irrational exuberance, to put it that way, because it was difficult to get the treatment out. We're now dealing with lots of issues around sustaining treatment, the side effects of long-term treatment. And you even have situations, I think, in Africa where almost majorities of populations are on donor-funded treatment, which raises lots of really interesting issues around autonomy in their own health system. So I think in this era we began to see much more emphasis on the biomedical strategies and interventions. And also the behavioral research started to switch more towards linking up to biomedical research. It was more about getting the factors that related to people getting access to treatment, why they didn't come in for treatment, how treatment affected behavior. And I think if I had to say, since about 2005 onward perhaps, there's been a bit of fatigue happening in the field. Donor fatigue in particular, and I'll show you a couple of slides later, but sustaining the amount of resources it takes to deal with the global epidemic has been difficult. We've had a worldwide recession, which has also strained budgets. I think interest levels have dropped. At the same time this occurred, there were a lot of interesting breakthroughs that I'm going to talk about that have revived interest. And really what's the theme now that we hear in HIV prevention and treatment is combination strategies, and I'll talk to you about that as I proceed. So I wanted to share with you a few studies I've been working on that illustrate some of these themes. Just to say, this first one was a project I did in the Dominican Republic. And prior to being in the Dominican Republic, I had worked for the Centers for Disease Control, and they sent me to Thailand to work with the Royal Thai Army with military recruits. In the northern part of Thailand, the prevalence was up around 25% among young military recruits coming into the Army, and it was an ideal population to do studies with because they had a random lottery that selected young men to come into the military service. So we had a good random sample, and we knew that the epidemic was really explosive. One of the gentlemen I worked with, Kamsam Nakpasort, who was a military physician, got together. It turns out in the studies that we did, we found that much of the transmission was occurring because these young military recruits were visiting brothels, which were very prevalent. So this physician decided to get together with the government and the brothel owners and try to jointly solve the problem of the risk that was happening. And one of the risks that was happening was that basically the brothels did not have a competitive advantage to promote condom use in these settings. If they did that, it became economically disadvantageous for them. So they decided to create what was called the 100% condom policy. And basically, this policy was a regulation of brothel-based sex work. There was mandatory screening for sexually transmitted infections for the sex workers. So every month, all the sex workers had to come into the health center and have a sexually transmitted infection test. If any one woman tested positive, then the brothel owner was actually fined, not knowing which woman it was. This put enormous pressure on the system, on the brothel owner, to back these women up and to mandate and insist upon condom use in that setting. They also had a graduated fine system, so if the first event occurred where there was a positive test, they would come in and really sort of counsel and talk to them. If it happened again, they would get a fine. If it happened a third time, the fine would go up. If it happened again, they would close the brothel. And they were pretty hardcore about this. There was a massive decrease in sexually transmitted infection, and we believe, and many analyses indicate, that this policy actually lowered the prevalence of HIV over time too. So this was really fascinating to see for me, and I was also working in the Dominican Republic, so we decided we wanted to replicate this, and it had never really been rigorously studied in a randomized trial. So we went to the Dominican Republic, and there was some very interesting people to work with there. Just to give you a little background on the DR, it had a long history of oppressive leadership under Trujillo, and around the time we started doing this project in the mid-90s, they had open elections and elected a new democratic leadership. So there was enormous interest in several things, a growth in civil society and NGO groups, and also a very strong emphasis on human rights came into play. So the government was really keen to sort of work with us and do these projects. And what we did is to picked two cities, Santo Domingo, the capital city, and Puerto Plata, which is another large city on the north coast of the country. And we randomly selected one to receive an enhanced intervention and one to receive a comparative intervention. So this is just a scene of the brothel situation there. The brothels are interesting in that country. They're sort of a hybrid with bars. People will come in and hang out and have drinks, and you may or may not go off with a woman. It happens off-site. They pay a fee to the bar owner and leave and go to a local hotel. That's sort of how the transaction works. So there are intervention components that we implemented here. There were 5 key components. And then both sites received these 4. One was a collective commitment. We did formative research with the sex workers. By the way, I want to just say one thing. It was a very interesting place to work because there was a union of sex workers. They had a collective union to represent their interests at the time. And there was also an organization, national organization of brothel owners. So that really was a great opportunity for us because we had representative groups to work with for implementing this. And when we did our formative research, one of the things we heard when we presented what happened in Thailand was that they felt the Thai model was too coercive. It was too sanction-based. It didn't have input. And that what they really needed to do was work together and have collective commitment among the sex workers. So that was an effort that was put into place. I want to just tell you the collective commitment aspect actually had a dark side too. Some of the women became very adamant that if any other woman went off and had sex without a condom, they were going to get back at them, they were going to get even. So it was a very tricky thing to manage that. We also developed in what we refer to as environmental cues to action. So we did formative research. We had the DJ occasionally come in and do HIV prevention and condom promotion. Actually, the people in the brothels came up with these ideas. We also, when they paid the fee, they automatically were charged for 2 condoms that they received when they left. So there was a variety of cues to action. We also worked very closely with the sexually transmitted infection clinic there to improve the environment, to make it more open and welcoming to sex workers. And we had a lot of monitoring and feedback loops, and that's actually something I learned from this project, that I believe in all of these projects are important to kind of constantly evaluate and tweak your intervention as you go. Finally, in Puerto Plata, we implemented a regional government 100% condom policy in collaboration with the government. I'll tell you a bit about that in a second. But it was similar to what happened in Thailand, although we added a secret shopper component into our intervention. It was kind of interesting. These were the outcomes that we looked at. So we had serial cross-sectional interviews, meaning we interviewed random samples of the women over time in 68 sex establishments in the 2 different cities. We measured condom use by partner type, adherence to the intervention, and obviously a host of socio-demographic variables. And then we had, probably should not have labeled this participant observation, maybe observation was a better way to go. But we definitely put in place a secret shopper program where we had men come in to work for us and attempted to negotiate sexual contact without a condom, and then that was one way they could fail their sort of test of reliance. We also measured, biologically, we measured sexually transmitted infections using ligase chain reaction DNA tests for gonorrhea, chlamydia, and trichomoniasis, because we wanted to have a really gold standard to see what would happen from the intervention. So we ran that out, and these were the results of the intervention. This is really showing the percentage of establishments in both cities that had no STI in the routine checks that we did over time. And you can see in the beginning it was pretty similar. We had some ups and downs, but over time this was a dramatic difference in the reduction in sexually transmitted infections. And we published this and did a cost-effectiveness analysis on this too, and found it to be quite a cost-effective intervention as well. In terms of some of the other measures, the secret shopper data was also interesting. Basically, these Confederates that we had would come in and try to negotiate an unprotected sex act. They go through 4 steps. They'd make a direct request. If they said no, they would say, well, I'm a clean and married guy. And if they said no again, they'd offer them extra money. And then the 4th step was to offer them even more money. If the woman agreed to an unprotected sex act, we worked really hard to keep our quality control on this. they cut off the contact and tipped them and left. And we found that over time, across from pre to post, because we only did this in one arm, in the enhanced arm, we saw a change from 50% at baseline of women agreeing to have unprotected sex to about 79% at follow-up, and that was statistically significant as well, as you can see from the numbers there. So I think this was a highly effective and cost-effective intervention, and there were significant changes in condom use and STI, both at the individual level and at the establishment level. We measured it in a group-wise manner. And I think this it was clear to us that this added benefit of the policy and regulation is really what drove these policies. A lot of interest was brought to this project after we published the results, and the national government went national with the program, and with funding from the World Bank actually replicated the intervention across the country. It's been harder to get other countries to adopt this intervention. There's a lot of pushback, there's a lot of concern about human rights. But I do think it well illustrates sort of the need to collaborate with the local partners to do formative work and to work across disciplines in the process of an intervention. So, you know, just in terms of where I went next in my career, around this time, treatment became more available. We had better diagnostics and screening capacity for testing people for HIV. And with funding from the U.S. Agency for International Development and some other colleagues and I put together a project to look at the impact of voluntary counseling and testing on risk behavior. It was a great interest of us. Here in the United States and in wealthy countries, it was readily available. You could go in and to a health department, for example, or to your physician and get an HIV test. And we had the belief that that test itself, knowing whether you're infected or not, was an important preventative issue. There wasn't great support for this. At the time, in most of Africa, there was no opportunity to get tested, and they had the highest rates of prevalence. And it was incredibly difficult for people, for women trying to decide whether to have, men and women trying to decide whether to have children, for example, whether to breastfeed. And then just the anxiety that it provoked in people alone were good reasons, I think, to test people. But we had a hypothesis that if you knew you were HIV infected, you were much less likely to transmit that infection onto others. So we did the first randomized controlled trial of the efficacy of voluntary counseling and testing. And basically, just in summary, the findings from this were we found significant reductions. We did a randomized trial and waitlisted some people to testing and compared them to those that got immediate testing. And we did this by opening a clinic. We had 3 sites, Trinidad, and then also in Kenya and in Tanzania. And in the combined analysis, we saw a significant reduction in unprotected sex with non-primary partners from this testing activity. And it was particularly pronounced for couples, and particularly also when there was an HIV infection present. So if somebody tested positive and they were a discordant couple, you saw enormous reductions in HIV. So we learned a lot from this project. We also did a cost-effectiveness analysis and found it to be hugely cost-effective. These numbers are leap off the page if you're familiar with cost-effectiveness. $8 per life year saved in Kenya and $12 per life year saved in Tanzania. This got a lot of interest. When this study came out, the field changed. I really do believe that this study led to a sea change in thinking about prevention, and the large donor agencies started to see HIV testing as a major component that ought to be put into place for HIV prevention. That led to some very interesting issues. So here we had lots of people getting tested. They started implementing testing programs, but there was no treatment. So you really created constituencies of people out there who knew they were infected, knew there was a treatment, and didn't have access to it. And I believe that actually led to political pressure for people advocating for treatment. And eventually, treatment did come online through an enormous program in the Bush administration, which I call the PEPFAR program. So some of the lessons we learned from that first randomized trial in Tanzania and Kenya and Trinidad were that there really were significant, I think, post-test support needs that people had. What we found, we trained people to do counseling, and these were sort of local, they weren't psychologists or psychiatrists, these were counselors that we trained from the local community. The people would come back after learning they were infected and had enormous psychosocial needs. There was anxiety and depression, concerns about disclosure were enormous, issues around stigma that people were facing. And we developed the belief that really ignoring these issues were a lost opportunity in prevention. Also, those who saw voluntary counseling testing in clinics, and that's the model we used, was to open a clinic, advertise the service, and have people come. We tended to draw very highly motivated people. And we realized we were missing lots of other people. We were getting lots of the worried well, who were utilizing resources, but we were also we were getting the people who were most seriously concerned about it because they had a loved one who maybe died, their partner had died from AIDS. But we were missing large swaths of the population. So there were lots of issues that drove people away around stigma as well when we only opened a clinic. The other thing we learned is the more you test in a community, the more you develop the desire for testing. Because people are fearful of doing that in the beginning, the more people know other people who've tested, it started to change norms about testing. We had indications that was happening. We also found that trust and confidentiality was a big issue for people, and that clients valued the counseling. When we first did our first study, we got lots of pushback. People were saying, oh, you know, in Africa, this idea of sort of sitting down and sharing your feelings isn't going to be culturally salient, but it really was not true. People very much valued the opportunity to have a confidential counseling session. So this really led us to some of our next studies. By the way, I want to say one of the other major challenges in HIV prevention is that it happens very quickly without any obvious signs. People get infected, there's few visual cues to the epidemic happening, and it takes about anywhere from 5 to 9 years for a person to develop AIDS. So in that time frame, the epidemic really can explode through a community without them having any realization that this is happening. This is another reason we felt it was important to get lots of people tested to learn their serostatus, because that can have an impact on the community. Also, stigma and discrimination were driving a lot of people to keep their infection secret. We felt the more we could encourage people to disclose and to talk about it and to be open about it, the better. There were a lot of biased beliefs about HIV that sort of, it's really the other. It's the other people, it's the other community. It's not people like me. So we wanted to test an intervention that would address these things, try to destigmatize HIV, enhance disclosure of HIV serostatus, take advantage of these sort of community dynamics that take place, and capitalize on the prevention opportunities of the post-test needs. So this really was our next big study, which was NIMH Project Accept. I actually skipped, there were a couple of pictures of students I forgot to talk about, but these are some of the students that were involved in this project. So this is Marta Malawa on the far left-hand side. She was a doctoral student of mine and went and lived in Tanzania, worked for MUSC, and lived there for several years and was our research coordinator in the site. Just going across, Katie Kern, by the way, Marta's now getting her doctorate at UNC in public health. Katie Kern, also a research coordinator there. This was an 8-year-long study, so we had a lot of people. Katie is now at University of Washington and just finishing her PhD in epidemiology. Lori Abler just finishing her PhD at UNC as well. Heidi Larry here on the right, and Amy Gragowski, both, she got a PhD in nursing, and Amy went on to work for an international organization based in Thailand. And this is Aaron Siegler, a very interesting guy. He's an anthropologist. He got his PhD in anthropology at Emory after doing this project. Aaron came to me in a class one day and said, when I was presenting on the studies, this is what I want to do. And gave him an internship. He went over. He got very interested in the project. He later went back and did his dissertation among the Maasai tribe, lived among them for a couple of years and did ethnography on HIV in that community. So there really are a lot of opportunities, I want to say, to students to get involved in these projects. I think we'll talk about them later. But in my own work, I just want to say it's been incredibly valuable to me to have student involvement. They're enormously helpful in the projects. And it's been helpful as well to have my own staff person based in country, so it's been a great thing for me. Let me just tell you a little bit about this study. This was a big project. This was funded by both the National Institute of Mental Health and also the National Institute of Allergy and Infectious Diseases. It was an 8-year study done in 5 sites in 4 countries, and you can see those listed. We had lots of institutions involved. We had Johns Hopkins and USC, the University of California, San Francisco, and the University of California, Los Angeles, who were all involved. We had 13 IRBs, just to tell you, which was a nightmare, trying to harmonize all these IRBs across these different sites, our institutional review boards for the ethics clearances. It was a great project. What we did in this study was to do a community randomized trial in these 5 sites. There were over 52,000 people enrolled in this study. And we had two types of interventions that we looked at. One was standard voluntary counseling and testing. You're going to see that coming up in some of the following slides. The other one, and this is really a clinic-based strategy, just like we did in the first project. The second thing we did was to do an enhanced intervention in the other half of the communities, which was we call community-based VCT or CBVCT. And for this one, we did community preparation. We had very intensive community preparation. I'm going to show you some slides of this in just a second. And I think it is a real theme in my own learning that it's critical to work very, very closely with these communities from the beginning, even in the design of the project. So we had a core protocol, but we adapted that protocol to each of the settings very carefully by working closely with community leaders and others in the community. We also did a lot of mobilization as the intervention ran forward. We enlisted community volunteers to go around and to be our sentinel in the field, because a lot of times rumors pop up in the field, and we relied a lot on the volunteers to help us understand the rumors and to get out and to try to mitigate those rumors that happen. There were fears that were expressed. We were stealing blood. There were all kinds of things that came up. We also provided testing and counseling, in this case, in a mobile context, and I'll show you pictures of this in a second. But we really wanted to get out of the clinic and get out into the community, and so we did mobile provision of HIV testing in mostly rural settings, very rural settings. We also integrated a post-test support service where we addressed things like stigma reduction, helping people cope with their emotional issues that came up around HIV testing counseling. But by the way, this post-test support service really mushroomed into a very comprehensive set of things that varied a lot by site. But some of the things that came up were the need and desire and interest in doing income generation. So we developed income generation projects. We had choral groups that formed to get together. It became very much a therapeutic community for people to get together and to support one another. We had soccer teams. We had all sorts of things that were running through this. And then we also had this, again, this sort of ongoing data feedback and to the field. It's a critical thing in these interventions is to constantly evaluate how things are going. When we had problems, we could detect we weren't getting uptake among women in some areas. We made special efforts to get out and address it. It really takes energy and effort to do that. You have to collect the data, you have to analyze it regularly, and you have to feed it back to people. That's the critical part. If you just sit in Clemson and analyze your data and you don't kind of constantly give that feedback, then people don't change their management strategies. The design of the study was, we did a baseline survey. It was a probability-based sample in the community. For example, in Tanzania, which is a site I ran, we had 10 communities. There were about 165,000 people that lived in that area. 5 of those communities were randomized to the enhanced, 5 were randomized to the standard intervention. And we had to go around and use a GPS marker to mark every single household in the entire district to get a random sample, to get a sampling frame for our random sample. Huge effort to do that. Then after we did our baseline sample and survey, we randomized the communities, and then for 2.5 years ran the intervention I just described to you. At the end of the study, we did a post-test assessment, which was done at the community level. And I want to explain that because most interventions you enroll a person as an individual, you sort of assess what you're interested in, you give them an intervention, and then you take that same individual and you see whether they had a change. But in this was a higher level of design where we actually did it at the community level. We wanted the entire community to have this change. So we did a random sample of the community at the beginning, ran our intervention, and then did a random sample of the community at the end. Many of the people sampled at the end may not have actually had the actual intervention, but we wanted to see the community dispersion and impacts of that intervention. So that's what that's all about. We did a behavioral survey. We also developed for this study, that's one reason NIAID, National Institute of Allergy and Infectious Diseases, put so much money into this project, was we developed an assay using, I'm not sure how much you know all these lab details, but using the BED assay, mean, you know, from the science side, we definitely needed, by the way, we need a lot of data management. I mean, the data challenges were pretty daunting. We try to get away from paper, you know, because there's so much paper moving around, there's a lot of chance for error. So this moving to the more electronic system has been a great thing. Yeah, but all the people you mentioned, I mean, I think you have to get the counselors, the nurses that we have. You have to get the manager types. This was a big project. I mean, this was a big boat to steer, so to speak. And you have to instill teamwork. And you know, we burn people out too, I want to tell you. They get up at the break of dawn, it's hard work, months and months of this. I do believe strongly that feedback loop is motivating people. You know, when you can sort of show them the successes and the benchmarks, and put a little pressure on them too to meet those benchmarks. I'm not sure I'm fully answering your question because I think it's a complicated answer.
But if you think about like a habitat for humanity type of setting where you have to have some carpenters, you have to have some plumbers, you have to have some electricians and whatnot, you know, so kind of down to the specifics.
Yeah.
So you're mentioning a little bit like computer scientists or, you know, information technology, but
It's, well, I mean, I think logistics, first of all, you know, I'm kind of coming at it from a researcher viewpoint, right? That's why I mentioned data right off the bat. But just running the intervention, the logistics of getting everybody together in the right place at the right time is enormous. You know, we have these spreadsheets with all these things that have to happen at different times. And it's hard, particularly in a case where the communications are challenging. You know, trying to move people into a community, you got to make sure you have the nurses there if somebody's sick. Transporting the laboratory samples was challenging. So, you know, I guess all I can say is it's hard. You need good managers who have management skills, which by the way is another unique skill set. That's just because somebody's a good scientist or a good computer technician doesn't mean they're good at managing people.
They'll be available for some more questions. We're running a little late because I started a little late, so we'll still have our 15-minute break. There should still be food. Go eat. Come back. After we come back, we'll do a career panel. So we have some speakers about kind of different career paths. Everyone's around for questions.